So you're all very, very welcome to our 7th Brca seminar. So we've had 6 in Dublin and it was time to get out of Dublin. So we're delighted to be in Cork. There is life outside Dublin and it's brilliant to be here. So I'm Bernie. I'm the Assistant Director of Nursing for the Keating Foundation and I manage our Brca services. So our seminar is one part of our Brca services. We also have our peer support volunteer service. And I'll be talking about that later. Let me know if the mic kind of comes and goes. I'll come a bit closer. And we have our Brca online support meetings as well. And the next one is May the 30th from 6 to half 7. They are free, but you need to register for those. And we have our Brca WhatsApp group. So I am conscious I have 5 minutes and I'm going to fly through this, get the important people up here to speak. So a few little things, housekeeping. So if we could have the phones on silent, if that's okay. And if you need to take a call, obviously just step out. Fire exits, there's the 2 at the end, but ideally we're told to use these doors that takes you out into the main foyers. Don't use the lifts and follow the fire exit signs down to the front entrance. Toilets, as you can see, are just outside and to the right hand side. Okay. And as far as recording is going, we're going to be recording some of the presentations and some for very good reasons we don't have permission to record. And there will be some photography or a few pictures taken going around the room, but no individual pictures will be taken without permission. So you'll see some signs up about photography there, but you know, we may take some group for, you know, to kind of pop on our website, but we won't take individual pictures without permission. If you have any questions about that, just ask any of our staff. We've got somebody out at the registration desk, I think Fiona, our Brca admin. And Helen is out here as well, and myself, Jane. So ask any of us if you have any questions about photography. So let's get on to the lots of thank yous, because we couldn't be here today without lots of thank yous. Because Keating Foundation, we are an amazing charity, but we're a small charity, and we do rely on sponsors for big events like this. So a huge thank you to MSD and AstraZeneca. You keep coming back again and again and again. And we couldn't do it without you, and we'll be back for next year. So, so I had to get that in. So thank you so, so much. Thank you for our speakers, expert speakers. We have such a panel of experts here today. Brca in the Horizon is the theme. So it's all things about where are we at with Brca, where are we going. So look, we've got amazing speakers here today. As well as that, our own staff. So there's lots of S's, the staff, the sponsors, the speakers. So Liz Yates here, our CEO. I think Liz is tired of me asking, can we have just a bit more, Liz? But she doesn't say no. So thank you, Liz. Thank you to Fiona at the very end, our Brca admin support. Helen, our Director of Nursing, is she here? I think she must be, there she is. How could I miss her? My left and my right hand woman. Lisa here, who is also Lisa McAway, one of our peers, who's also going to also works with us, and you'll be seeing Lisa later on. And behind the camera is Jane. Jane, our communications manager, who's fantastic. So Jane will be recording the presentations we can record, and they'll be available probably in about a week or 2, yeah, on demand, anybody that wants it. So we have recordings of all our previous webinars as well. So the staff here as well in the Clayton, and Liam, who was called after Liam Neeson, who's been such a support for us here, Matt Radman, all the staff here at the Clayton, they've been fantastic. Stands, you'll see as you came in, there's lots of great stands out at the foyer, out in the main foyer out there. We have Start Off ourselves, Keating Foundation. ARC is there as well. We've got Etna from Supreme Silhouettes, who's got a lovely selection of bras and swimsuits. We've also got Blinks and Brows as well over, and Blinks and Brows, have to get and make sure I get my names correctly. It's called menopause. Your name's kind of rather than it. So yeah, we have got from Blinks and Brows, we have Teresa O'Leary, and I believe she's going to be giving out some yoga mats as well. So yeah. So some great, and also Christina Cahill is going to be here from UCD, and she's in UCD doing her PhD and also working with St. Vincent's Hospital and around the country, looking at the psychological impact of Brca and all other high-risk family cancers. So she's there, have a chat with her about her research if you're interested. So let me see, who have I forgotten? I hope I haven't forgotten. I have. How could I forget? Our peers. So we have 10 amazing peer support volunteers. I'm going to be talking more and introducing you to 6 of our peers that are here today. And Melissa is in online. Hi, Melissa. So, and we will have 2 of our wonderful peers. We have Jean, and we'll have Jean up here and Lisa talking with genetic counselor Maria Duff towards the end of the day. Really, really good, you know, insight into the personal impact of BRCA. So, and yourselves, we couldn't, it's like making a good cake, you need all the good ingredients. So we've certainly got all the ingredients. Thank you, every one of you, for coming today. You know, you've come from all around the country. You won't be sorry, because it is going to be a fantastic day. You will be receiving feedback forms in about a week or 2 from Fiona, and we really appreciate your feedback. Our theme for each year and our speakers for each year is what you guys ask us for. So in planning ahead for next year, let us know, you know, what topics you'd like covered, etc. So I think my 5 minutes are definitely up. So thank you so much. So first up will be, if we move along, but I can show you a picture of our wonderful panel there. But Mike kind of, you probably can't hear me. There's a wonderful panel. So Dr. Caitríona McCarthy is a medical graduate of UCC and works as a consultant in public health medicine with the HSE's National Control Programme, the NCCP. Her areas of work include health improvement and health service improvement, including the development of services for those with an inherited predisposition to cancer. So Trina is going to come up and talk about the hereditary cancer model of care. So I'm just going to pop up Trina's presentation here. There we go. Okay, thanks for
Thanks for the introduction, Bernie, and good morning to you all. As you may have picked up here, I'm Cork born and bred, so delighted that the meeting has been brought to Cork today, and welcome to anyone who's travelled here. So I work in the National Cancer Control Programme, which is directed within the HSE, and obviously look at cancer services across everything from prevention to treatment services to survivorship. And what I want to speak about today is our model of care that's been developed for hereditary cancer. And I suppose in terms of our Bible within NCCP, the Cancer Control Programme will be our strategy. So this is how we try and argue for funding from the Department of Health and within the HSE, that, you know, to implement the recommendations. And there are recommendations in there around you know, an inherited predisposition to cancer. And more broadly, I suppose, you know, genetics and genomics and that whole area really was recognised as something by the HSE that Ireland needed to focus on and develop. And, you know, that I suppose technology and the ability to manage the conditions that people had, you know, that was moving beyond sort of our capacity. So this second strategy here is one around genetics and genomics in general. So very important still for, you know, people within the BRCA population in terms of building those resources within Ireland. So that is about looking at, you know, the workforce that are in genetics, which again would cover cancer genetics, but also other rare diseases or things like cardiology and epilepsy and all of those things as well. You know, the testing side of things, and you know, what technologies we have, but then also the management services. So very specifically, I suppose, from the cancer side of things and genetics, some of you might have heard about tests that happen on, say, tumour tissue in cancer, and sometimes that's, you know, to predict what treatments will work best, you know, for an individual person. This particular model here is really more focused on, you know, what's been inherited or an actual predisposition in an individual and how those services need to be developed. So again, that will cover people who both have had a cancer themselves, and that might be how someone discovered they had BRCA, or say Lynch if it's bowel cancer, or, you know, there are other examples across cancer, but you know, you can be diagnosed that way, or it could have been something that it's through a relative been found to have BRCA, that's how it was discovered. So you know, this is services for people who haven't had a cancer diagnosis as well. So the point of developing that model of care was really to say, look, we need to look at this across, you know, what is required for Ireland, and you know, without going through all those steps. I mean, I think the BRCA population in Ireland and the peer support group and Mary Keating Foundation, I think, really fed into both this model of care and the broader piece for genetics through the Brca needs assessment that was done, and sharing, the challenges as an individual with Brca and what's required at all the different stages. So that was really, really informative. And there are some other projects that said in bowel cancer, those that also fed into this. We had a very engaged advisory group and excellent patient representatives there again in Nikki and Rachel. And that model care, as I said, was out for public consultation as well, and culminated with it being launched in June of last year. I actually bought a copy in my bag, actually, if anyone feels like flicking through a hard copy. But so here are some of the excellent people who you may recognise a couple of from the room today who contributed, who were at our launch. And without going through the whole model care, I think just maybe picking out some of the themes and showing you, like, the vision for it obviously was, some really strong things that came out around equitable access to service. And that, again, will be both at the start of your journey, maybe in terms of trying to get a diagnosis, but then also, the management services in terms of whether it's surgery or, your breast imaging or any of those things later on, that should be equitable to all, and having that in a coordinated way and timely way, having good information and psychological support, and then also the whole development of the healthcare network around you, having stronger national guidance and the slow into care principles I mentioned there. But that's really about getting the right treatment in the right place at the right time. So the really kind of just bird's eye view of what the services, what we want them to deliver, I suppose, is that orange bit there is your generalist services. So you're really talking about you want your GP to know what, how to support you, to recognise what pathways should be used for people, or if it's maybe general gynae services, so people even who are outside of oncology or knowing too much about cancer, at least knowing the basics to start with in terms of signposting people the right way. And then the regional, that kind of yellowy bit in the middle. So the regional cancer predisposition services, so the vision for that is to have reasonably comprehensive services in the hospitals around the country, which don't just look after the person who's had a cancer diagnosis, but also look after the side of things for cancer predisposition. And it's quite comprehensive what we hope to get to in terms of everything from, again, getting your diagnostic tests and your counselling more regionally. So having, as you see the little bubble in there, having genetic counselling services reaching out into those regions, having teams locally, again, knowing what tests to do, what tests to order, and then again, once you have a diagnosis within your region, having those services available in terms of your management. So again, your surveillance, your surgery, your other supports in terms of, say, reproductive advice or psychological support, having those and being able to access them anywhere within the country. And then, of course, you need that specialist, core. We have some excellent professionals within the country, but just making sure that we get the best use of that team, and that we grow that team, and that we support them to support the wider workforce as well. And again, that no matter where you are in the country, that you can get that sort of expert opinion and expert advice when required. So the themes in terms of, I suppose, what's to be implemented under this model of care, we've sort of the oversight piece, which is the top bullet there, and that's the steering group, which has been set up to oversee this implementation. So special call out to Lisa, who's here, who's one of our patient public representatives on that group. And that steering group is really to sign off on any of the processes, the priorities, and receive reports on the progress. And then within the other areas, I suppose, to drive the work on the recommendations within all of those. So that's kind of just kicked off really at the end of last year and into this year, but really is to put, focus on some of the practical solutions that we need, and also use that to, at the end of the day, we need resources, we need funding, we need, the HSE to write a few checks as we go along. So I suppose it's really, you're doing that, but against a plan, and you're showing that this is the need of the patient group, and this is how we're going to deliver it in the best way possible. So just to mention a couple of the groups, and just to show you the pieces that are kind of kicking off in terms of the network services and the MDTs being the multidisciplinary teams. So this is particularly where you want to get advice on a particular person's, either their genetic results or the best means of management, that, you know, having a network across the country is very important for that. So the things that need to happen there is we're looking at developing a lead, so having a clinical lead within each region to take responsibility, I suppose, for those services in their areas. And 2 of the new consultant medical oncologist posts that have gone into the system have taken on that role. So there's somebody, you know, with an interest in genetics who's kind of, I suppose, going to be your clinical champion in a particular area. So I think that's something that will be very helpful, you know, that you might have a cancer clinical director, but you want somebody there saying, I'm speaking up for the people with an inherited predisposition, and in our area, we're really bad on X, you know, we need to focus on fixing X first. So that network would be really important. And also, as I said, in terms of those 2 kind of NDTs that you can feed into. And then I know Rosie will speak, I'm sure, quite eloquently on genetic counselling and the importance of it later, and what needs to be built there. But it is a real kind of fundamental one that needs to be built and networked across the country. So again, that's one where it was in particular we're working with the National Genetics and Genomics Office as well, and we're implementing the general genetic strategy to just look at what things need to be fixed in our healthcare system, I suppose, to support the growth and the training of more genetic counsellors, because I think a lot of people have pointed out this is an area that's not getting smaller, it's getting bigger. You know, we're going to need more people working in this area. So how can we make sure that happens? In clinical guidance and development of pathways, just again, some of the priorities for 2024, the General Genetics and Genomics Office has prioritised the genetic testing directory, and again, that would be something that would be across rare diseases and cancer, and tumour testing will also be included in that. And the benefit of that, I suppose, is really, you know, they have a version of this in the NHS, and I suppose we need something like that for Ireland. And it's to be very clear on, you know, which tests should be carried out for which person and who can order that test. And again, that will really help the sort of mainstreaming approach, where if you're going to have people outside of the small specialist group ordering tests in certain situations, then, you know, they have the assurance this is the guidance on the test, you know, you're getting the right test, you know, what test to order. So that's a priority piece from our end in terms of the getting the right diagnosis for people, and that's something that we're kind of kicking off the process on that from the cancer predisposition side. Another piece, I suppose, that's been raised has been that, look, we have a lot of international guidance, such as there's European reference networks around cancer predisposition, and having, you know, how can we just look at having a proper process for agreeing those for Ireland, and then, you know, if you've agreed nationally, these are the steps that need to happen in management, then you can go and fight for it. Now we need the resources and the money and the people to make that happen. And then I think a really important one that's called out, but especially in our recent steering group meeting, the resource requirements for, you know, putting these into place, that it's not just about the getting the diagnosis at the start, but it's also about, you know, getting the services you need, you know, over many years. So I just wanted to pick out a couple of things, I suppose, where there's overlap, where some of that work has already happened, and that are relevant to those of you in the Brca population. So we know what things need to happen maybe in the pathway, but surveillance, for example, is one that, you know, you're getting your MRIs or getting your mammograms, and it wasn't just a COVID problem. You know, it was a problem before the pandemic. It was sort of exacerbated then, and it's still a challenge because there's such a demand on those services for people who already have a cancer, or people who are coming in through the emergency department. You know, it's coming at the hospital services from every direction. And it was really one thing that we're really fighting for, is that they would be protected slots for very predictable need, you know, in a group of patients. And that's, you know, the one very big group is those with inherited cancer predisposition. There's another group, say, in terms of people who had cancer before and need some follow-up surveillance. So how can you take that? So we're looking at, you know, in the diagnostic space, the radiology space, can they take that away from competing with the emergency department? Because it shouldn't have to do that, you know. So that's really like a big ask from our end, is that we want to have dedicated slots for imaging, and that makes it much more protected, we'll say. And then while within that project, I suppose we're careful to say, you know, population screening in terms of breast screening is a different thing in terms of people getting their letters in a post and a call for mammogram, but they have a good sort of IT system and structure for calling and recalling, and, you know, if you've changed GPs or changed, you know, to try and remind people about the tests that are required. So again, that with that breast family history project, which is said is across the whole, sort of somebody just with a relative, maybe with breast cancer, all the way to somebody with a known, you know, genetic reason and a cancer predisposition, that, you know, having a good call recall system, I think is, you know, something from a quality assurance point of view, and being assured that you'll get the test you need when you do. And that's something, again, that we're working with the screening service and using. The other big piece to mention, I think we've known there've been like a lot of challenges in terms of people getting their preventative surgeries, particularly with getting your breast surgeries and your reconstruction. And I mean, it's great that what's the word, you know, science has moved on, and the sort of the quality of the surgery is so good, and you know, the outcomes are so much better, but it's a longer procedure. And that, I suppose, has been one of the issues that has really put a lot of strain on the system in terms of getting access to theatre. So there've been extra staff put into the system, but problems that we hear all around the country is trying to get into theatre. You know, we actually have the breast surgeon, we have the plastic surgeon, we can't get the theatre time. And it's, again, something that we sort of put on the kind of front of the ask from the NCCP and within the HSE, that infrastructure is the big block here. You know, yes, we need to continue to grow the specialists and have a good service in prophylactic surgery, but it's the space in theatre. And again, having that sort of dedicated infrastructure is the big thing we're pushing for. I just wanted to mention that there is, as you probably know, buildings and infrastructure take a little while, so we want to have a more kind of immediate solution in the short term. So there's something called the Access to Care program, which is using sort of the private sector to provide services. And they've been absolutely on board with this in terms of working with individual hospitals to try and get, you know, surgery provided in the private sector. So at least you don't have the mismatch between, you know, the surgery is available, but only if you pay for it. So people can access that through their individual hospitals. And some hospitals have, you know, are working to maybe try and move other surgeries out to the private sector to free up theatre capacity and do the surgery in-house. I don't mind which way works in the short term. I just want to make sure that patients can try and get through the system. But just so you're aware that that's there, and that they're working with individual hospitals to try and push that along. So just to summarise, I suppose some of the priorities is really about getting those network services and the access to those specialist teams up and running. Having the guidance directory, as I said, is one that's already been looked at. Improving international guidance, and of course the resources to go along with this. And then one of the priorities raised that we haven't started for this year really is around the data and the IT infrastructure. And I think, you know, one of the important things here is that, you know, having a means of measuring people's journey in the pathway. That's often, we know there's issues and blocks, but if we can measure it and show improvement when we develop the services, and it's just very powerful. I suppose individual stories are very powerful too, but at a national level, to be able to say that this is the demand and this is how we're getting there. I'm not expecting to read this one, but just to show these are all the actions under all the work streams, just to give you an idea. There's a lot in the model of care, and these are I suppose some of the areas that we've kicked off on at least. So it's a bit like, you know, baby steps forward, but at least we're going forward and we have a plan. So Rose is trying to keep me optimistic that we're going in the right direction. So we're going one step forward instead of two back. So there's a lot of work to do. And I suppose just again to thank the Marie Keating Foundation and the peer support workers, and in particular the patient and public representatives on the previous pieces of work, Lisa currently, and you know, will be asking for more. I'm sorry, I'm always coming to ask, but it's just really powerful to have you know, somebody in the room who's experiencing, you know, the challenges in accessing the services. You know, you just can't beat having that kind of directly there, and I really appreciate it. So thank you for listening today, but also thank you in advance for future help as well. So thank you.
Thank you so much, Caitríona. No better person to have at the helm, but yeah, we just need the HSE to write the checks. So yeah. So listen, we will have a Q&A section just before lunch, and you'll be able to ask some questions, and we will be having coffee break 11:15 to 11:45. So let's keep moving here. Oh, I actually have to come out of your presentation. Bear with me. Right, let's see. Do behave nicely. It's not moving here, but it's moving there. Okay, so next up is Dr. Rosie O'Shea, and just need to get your slides moving on the screen too. That would shorten that 2-year wait list to be very well. Yeah, thank you so much. Yeah, I forgot that one. Okay, so next up is Dr. Dearbhaile Collins. You can sit for 10 minutes, but don't tell me. So Dr. Collins is a consultant medical oncologist and clinical director of cancer services at Cork University Hospital. She has a subspecialty interest in gynecological and thoracic cancers, as well as translational research and early phase trials. In addition to her medical degree from UCD, Dr. Collins has a PhD in translational oncology from National University of Ireland, and a master's degree in medical ethics and law from University of Manchester. Dr. Collins didn't get bored. Wow. So, anyways, I think I have to get back in here. So, I'm postgraduate certificate in clinical and translational medicine. Following specialist training in medical oncology in Ireland, she undertook a fellowship at the Drug Development Unit at the Royal Marsden and Royal Marsden and Institute of Cancer Research in London, UK, before returning to CUH. She is very heavily involved with clinical trials. She is Cancer Trials Ireland, Gynecological Cancer Clinical Trials, that is a mouthful, co-chair and the Cancer Trials Ireland representative at the European Network of Gynecological Oncology Trials. She is principal investigator and member of a number of scientific advisory committees of international cancer clinical trials. Her translational research achievements have led to being awarded the Irish Cancer Society Clinician Research Leadership Award in 2020. Dr. Collins is the national lead of the CTI Irish Molecular Tumour Board. She is also co-founder of the Women for Oncology Ireland and has recently become the president of the Irish Society of Gynecological Oncology. She is involved in many NCCP expert advisory groups and acts as the medical legal expert, and is involved in groups striving for equitable access to cancer treatments. And before Mother's Day this year, she was mentioned by the Irish Examiner as in the top 100 women in Ireland, improving and making changes to healthcare in Ireland, as well as numerous tops in research. So Dr. Collins will present on ovarian cancer, primarily looking at Brca alteration and its latest treatments and clinical trials. Want some water?
I would actually.
Yeah.
There was something I wanted to use.
Yes.
Thank you so much for having me today, and I would have sent in a short bio if I had known you would have that. So I'm a gynae specialist, so I treat gynecological cancers, some other cancers, but I have a high level of interest, obviously, in ovarian cancer, and I'm the president of ISGO, which is a group I'd all recommend if you're interested to get involved in, because we're always welcoming patient involvement, and we have very Yvonne Amara and Sharon O'Toole who run a really strong PPI group there. So oh yeah, okay, sorry. Is that the old one side?
This is the new one. I can minimize it because I got separately.
Because it's a different color.
Oh, is it?
Yeah.
I might have changed to a different
I thought it was purple. Oh.
Okay. So maybe if we put in here.
Yeah.
Yeah. Try it on. Perfect.
It's purple, the purple through.
So
Great. Well,
Tech.
no, great. Excellent. So I wanted to touch on three things. I'm going to try and keep to time. So I want to talk a little about ovarian cancer with focus on BRCA. I want to talk about the evolution of how we've developed the BRCA-directed therapies, in particular PARP inhibitors, because they've taken a long time to come and they're moving very quickly. And I want to talk about some challenges with the PARP inhibitors and steps forward and put on my Cancer Trials Ireland lead hat and talk some of the trials that are coming. So ovarian cancer, so we talk about ovarian cancer, but actually it's a group of very diverse cancers. The BRCA, I suppose, driven side of things is predominantly in the high grade, especially the serous, which is the blue box there. But we do see BRCA driven cancers in endometrioid, although probably less than 10% and a little bit rarely in clear cell. Not usually elsewhere, but when we talk about ovarian cancer, all these cancers behave very differently from an oncological point of view. So they respond differently to treatments. They have, I suppose, different sensitivities. Some are more hormone driven, and that's because inside the cancer there is a DNA that has its own, mutations that dictate its behavior. And BRCA is one of those. That sits predominantly in the high-grade serous, but as you can see, each of the ovarian cancer subtypes are very diverse and different, and that behaves their underlying behavior, and we are developing targets for many of these. So if we look at the high-grade serous cohort, we can see that there's the germline or the inherited BRCA sitting in around probably less than 20%. We also have abnormalities of the BRCA gene within the cancer itself, so that it's not inherited, that it's only in the cancer, but we treat these very similar to what we would with the inherited BRCA cancers, and they include BRCA mutations, but also a silencing mechanism of the BRCA gene. And there are other abnormalities and other mutations you can get in the DNA repair pathways, in addition to some other abnormalities. And all this group here, this kind of 50% group, they behave relatively similar, probably going from the germline BRCAs, for example, and the PARP inhibitors respond the best, with the kind of the lower likely HRD, we call them, or BRCA-like cancers behaving a little bit less sensitive. And then the cancers on the other half of that pie chart are usually not driven by BRCA and problems with DNA repair pathways. So if we look on whole, the BRCA variants, about 15% germline, another maybe 7 are within the cancer themselves, somatic, and about 13% maybe have some silencing mechanisms. So it's a significant portion of the ovarian cancers that we manage. So BRCA 1 and 2, we know that they're sitting on chromosomes 17 for BRCA 1 and 13 for BRCA 2. They're also dominant, which means that they inherit, there's a 50% chance of passing them on, but also, and then they have the higher risk of developing cancers of breast, ovary, male breast cancer, prostate and pancreas, and they're not to be forgotten. And often there's obviously such because there's such an incidence over a higher incidence of breast and ovarian cancer, we do forget that prostate and pancreas sit in the background as well. We are developing BRCA testing for these pathways in conjunction with the NCCP, so we can detect this, because this obviously has implications for family. So the BRCA 1 and 2 mutations, when the BRCA genes are mutated, they inhibit their natural ability to repair DNA. So BRCA normally fixes problems with the DNA as the cells are dividing. But if there's a mutation or a problem with that gene, they're no longer able to do that. So chemotherapy and PARP inhibitors also cause DNA damage. So that if you have a BRCA mutation, you tend to be more sensitive to chemotherapy and PARP inhibitors. So if you look at patients who don't have BRCA, the BRCA patients tend to respond better to chemotherapy the first time around, and they respond better to chemotherapy the next times round. So the second and the third time we go compared to patients who don't have BRCA genes. And there is actually a better overall survival for ovarian, this is all ovarian cancer data, from both diagnosis and also when the cancer relapses because of this inbuilt sensitivity to the chemotherapies and the PARP inhibitors that we use. It is worth pointing out that BRCA is not the only reason for why patients get ovarian cancers. There are other genetic drivers. And there is a case, and we are moving towards a situation where we're not just looking for BRCA when we have our patients with ovarian cancer, we're also looking for a wider panel of genes that might impact or might drive an increased chance of developing ovarian cancer, both patient and family, and that can include the Lynch. So I'm going to pop this up. This is this inside the cell. We've gone inside the cell, and this is how the DNA, and it's our lovely green and blue DNA at the top. So the DNA, your DNA breaks or makes mistakes for many, many reasons. Light, radiation, chemotherapy, just bad luck. And depending on the way the DNA has broken or made a mistake, whether it's a single strand break or a double strand break, we have inbuilt within ourselves ways of fixing those errors. So every day and every time a cell divides, there's a very high likely chance that a mistake will be made as it's copying one set of DNA or its set of DNA into its daughter cell. But we have really robust DNA mechanisms that fix those problems on a regular basis. The problem is when those mechanisms let us down, that can potentially lead to cancer. And if we look, I suppose, where does BRCA live? So if you've got a problem with BRCA, it means that your double strand break pathway doesn't work properly. You have other pathways, but therefore your body will rely more on the other pathways. But that's kind of where the abnormality sits. There are other genes that you might notice that also behave like BRCA. So these are the MMR genes, MSH2, MSH6. MLH1 and PMS2, and they're involved if they're abnormal in Lynch syndrome. And that's why Lynch syndrome also has a predilection for cancer. And again, it's all part of inability of the cell to develop or to fix its mistakes. And if you just look over to the single strand break, you see what I've already mentioned, which is PARP. This is what the PARP inhibitors are targeting. And I'll explain a little bit later why we don't target, the BRCA, or why we don't target somewhere else, and why the PARP inhibition is working. So currently at the moment in ovarian cancer, we have NCCP supported BRCA1 and 2 testing at diagnosis, and once a patient is known to be sensitive to the cancers that we're giving, but we only test for high-grade serous and endometrioid ovarian cancer. And we get a dual testing. So we get a test of both the blood and we get a test of the tumor itself. Because of trials that have come through, we have moved, just to point out, this was driven by Cancer Trials Ireland study that AstraZeneca strongly supported called T-BRCA. And that was the first study. Roshni Kalitan and Brian Hennessy up in Beaumont really drove this. And that's what sort of laid the groundwork for BRCA testing. Because of some changes in what we've had in trials, we've recently added HRD testing, and that's kind of complicated things a little bit, but what it's looking for is BRCA-ness. So there are cancers that I said that don't have BRCA, but behave like BRCA. And these we call in kind of an umbrella HRD positive or homologous or combination deficient. And they are basically, and this is kind of very sciencey, but there is a number of different ways in which this can be tested, but ultimately it's showing the instability of the DNA. So if you've got problems repairing your DNA, you'll make lots of mistakes, and that makes the whole kind of genome quite unsteady and unstable, and lots of small little errors are being made, and these tests set out to look for that. We've got quite well-known ones. Myriad's My Choice and Foundation One have the kind of most common ones. Just to point out, the clinical trials that are running, some of them use Myriad, some of them use Foundation One, some of them use others. So it's difficult, to fully, because they do test different things, and that does make a little bit of challenge sometimes fully when we're trying to compare studies, which is hard anyway. I'm going to go back to some other cancer types because we're talking very much about ovarian here. So obviously breast is the bigger pie because of its increased incidence. So less germline BRCA and somatic, but there are groups that have this BRCA-ness, that yellow piece, that behave more like Brca. Pancreas is similar, so with the grey is Brca, the green is inherited Brca, the green is the tumor Brca, and the yellow is the BRCA-ness, and prostate as well. So if I touch on how we got to the treatments that we've been to, or we now have, so how do PARP inhibitors work? So in a normal cell, if you make a mistake, the DNA is repaired and the cell survives. If you have a BRCA gene, if there's a mistake, like a mistake can be made, but the DNA can still repair based on all those other pathways, so the cell survives. If you give a PARP inhibitor without a BRCA gene, the PARP inhibitor will block that single strand pathway, but the cell switches to use the other methods and the cell survives and the DNA is repaired. But if you have both, if you have the BRCA mutation and you use a PARP inhibitor, you've now knocked out two of your cell repair pathway, and the cell can no longer, it becomes so genetically unstable and it collects so many mutations that the body will get rid of it. That's how, and that's a concept called synthetic lethality, and that's how it works. So we've been looking at PARP inhibitors and PARP itself in this path since the 1980s. But as with a lot of research in science, it takes a long way to get from the lab and from the cells in a Petri dish right up to an actual treatment. So the first phase 1 dose finding, where we looked at a lot of different cancers, was in about 2007. By about this stage, they were seeing I suppose a difference in cancers that were BRCA driven and more sensitivity. 2009, we looked at it in platinum-resistant ovarian cancer in the Royal Marsden predominantly because they were sort of leading out on the PARP inhibitors. But study 19 was the real first study that has got to us from where we are today, and that divided into BRCA mutants and mutated and BRCA non-mutated. Solo 2 came 2017, the year later Solo 1, which I'll talk about, and the year later. So it's coming thick and fast now and things are changing quickly, but it has taken a long time to get here. This olaparib, which we know, and it was one of the first PARP inhibitors that we used, was originally known as KU59436, and that's how these drugs come through. They become their numbers and letters and names before they become names. It was bought by AstraZeneca and then it became AZD2281. And when I joined the Royal Marsden, that's what I would have called it as. I would have said, this is the study on AZD2281, and I didn't even know it was called olaparib for another little while. So we were seeing some really excellent responses, about 46%. And these are patients who had had lots of chemotherapy and lots of treatments beforehand. Study 19, I talked about here. If we look at just the BRCA, so we can see a significant change in using olaparib, but again, these are patients who had treatments before, and so we're not seeing that big improvements that we move on to now. Solo 1, looking at just BRCA mutation, Solo 2, looking at just BRCA mutated, we're starting to see the big gap now between, if you get a PARP inhibitor, the impact that that's having on overall survival. And now, of course, we use Solo 1. So if you have a BRCA mutation, Solo 1 is the study that looked at olaparib alone versus doing nothing. But the problem with that is that we don't always do nothing when we're treating patients who've got ovarian cancer. We sometimes give a drug called bevacizumab, but the problem is bevacizumab was not included in the study. It was just olaparib versus nothing. And it's fantastic results. So at 7 years, 67% of patients are still alive. And these are patients with stage 3, stage 4 ovarian cancer. So remarkable improvements and a benefit to patients. We then had a whole bunch of other studies looking at not just the BRCA patients. Prima looked at another part called niraparib. It was a very high risk. Cancers were ones we kind of expected to come back because of cancer left behind or patients didn't get to surgery. So I suppose the numbers are lower than what we see in the olaparib Solo 1 arm. We also have Prime, which is a Chinese kind of repeat of Prima, and most recently Athena Mono, which we had here in Cork in Ireland. We've got some ladies on that, and we don't have survival data. This data is just coming through, but you can see that, you know, from this is PFS is progression-free survival. So patients who didn't get rucaparib most of their, on average, their cancers are coming back after at about 14 months, but we still haven't reached that average, which means that it'll probably be over 30 months at least, if not more. So this is the magical called Kaplan-Meier, and these are the patients on the blue line are those that got olaparib, patients on the gray line are the ones that didn't, and you can see that benefit. And there is a possibility that there are patients in the blue line who got olaparib that will never have a recurrence, and that is very exciting, and that is a game changer. So we recently got Paula-1 came out, and this also included patients with BRCA mutations, but also those that didn't. So the BRCA mutations are here. Now this looked at olaparib with bevacizumab versus bevacizumab, but didn't look at olaparib alone. And this is the problem with studies. So we can't compare the two studies. So when I'm faced with this, this clinically, it's a very difficult decision whether you give the patient just olaparib or whether you give them olaparib with bevacizumab, because there's additional side effects the more treatments you add. There will be studies hopefully coming out this year, which will help us with this answer. But again, PARP inhibitors for BRCA mutations are absolutely part and parcel. And so this is kind of the landscape that I have to do. I have to kind of make a decision about whether we're going solo one or Paula one when we've got someone with a BRCA mutation. So the problem with the PARP inhibitors is they don't always work. And some of this is because the BRCA reverts, which is a testament of how remarkable cancer cell is, remarkable in a bad way, in that its ability to adapt and evolve based on treatments is difficult to stay on top of, I suppose. And then we just finished up with some of the clinical trials that we have. So not all patients with BRCA mutations respond to PARP inhibitors, and this is a very, I suppose, challenging area. And some of that is because the gene, not in the blood, but in the cancer, reverts back to working again, so that the patients don't have that sensitivity that if they still had the mutation in the cancer. There are, just of a note, there doesn't seem to be any difference between BRCA1 and BRCA2 as regards how they respond to PARP inhibitors, so the two genes, the two mutations themselves, but the mutations within the BRCA1 or the mutations within the BRCA2, there may be differences within the very specific mutations when you really look at it. And this is some post hoc analysis that came out of Paula-1, which we're kind of still learning about. So this is just, I suppose, one of the big reasons of PARP inhibitor resistance, and this is the secondary BRCA mutation. So the BRCA is mutated within the tumor. It develops a new mutation, which makes the BRCA work again. And we looked at this was data from the Royal Marsden when I was there, and we looked at, when you've been on a PARP inhibitor for a while, sometimes your cancer in areas might start to grow, but in other areas it stays quiet, and this differential response. And we did, we kind of, this happens pretty frequently, and definitely the general consensus would be to try, if you have an area that's resistant to PARP inhibitors, to try and manage it in a different way, but then continue the PARP inhibitor that's working on everything else. So use radiation or sometimes surgery or some other mechanism in order to try and get rid of that resistant pocket. So one thing we haven't really figured out yet is if you've had a PARP inhibitor and then the cancer comes back, can you have another PARP inhibitor? And we don't really know this yet. We've got a study called Oreo, like the cookie, which looked at PARP inhibitors after PARP inhibitor and showed a small amount of benefit. But the absolute caveat here are these were not patients who got the solo one, patients that what we're giving now, the PARP inhibitor first. So we don't know really how well a second PARP will do afterwards. Because Oreo is not reflective of the current, of how our real world patients are now. And that's because things are changing so quickly and treatments are changing so fast. So this is a study that was done, and it's great that we have studies that are being driven by investigators, but it I don't know whether PARP inhibitors will work again the second time around. we do think that there's probably a degree of resistance, especially if you've been on a PARP and the cancer is growing. So what we're trying to do is we're trying to combine PARP inhibitors with multiple other agents. So we're looking at other parts of the DNA damage pathway. So we've got WEE1, and ATR inhibitors coming down the line. We've got drugs like bevacizumab, cediranib, which we're looking at in combination, targeted multikinase inhibitors. These are drugs like lenvatinib that just target a whole pile of things in the cell outside of the BRCA side of things. There's very novel targets coming out from research in the labs. We are still looking at immunotherapy, even though immunotherapy has not been shown to be a benefit in ovarian cancer. Different strategies are being looked at, and then there's other things being researched presently. But actually, one of the big things we need to do is use more dynamic biomarker testing. So looking at circulating tumor DNA. So your cancer can shed into your bloodstream. So you can pick it up usually in your blood. And you can test that and look for resistance mutations or circulating abnormalities that might be able to predict what treatment suits you best. So we're moving into a more personalized, individualized cancer treatment strategy, and that's being driven by this circulating tumor DNA, which obviously we can get much quicker than we can see, or much more regularly than we can a CT scan. This is where we sit with our Cancer Trials Ireland gynae cancer clinical trial portfolio. You can see there are gaps, which is something that we have worked really hard to try and improve. We want clinical trials available for as many patients as we can, and it's really disappointing, especially in the cervical sphere where we are at the moment. And we're really trying to, I suppose we go to Europe and we work with NDOT to try and encourage trials to come to Ireland, but we're a small population and don't contribute hugely. We also have very low accrual to clinical trials, so we only put about 3-4% of our population on clinical trial, but we really should be above 5%, even closer to 10%. So in ovarian sits on the my right-hand side, just the left-hand side of the screen, and you can see that we do have a lot coming actually. What we have mostly coming are these things called folate receptor alpha and ADCs, or antibody drug conjugates. Which are, I'll explain to you now. So we've got mirvetuximab soravtansine, luveltamab, tazevibulin, I don't know why I come up with the names, and a novel F4 alpha ADC, which is a phase 1 that's coming. But these are antibodies that stick to the folate receptor and have attached to them a stealth bond of cancer, of chemo. So they're like targeted chemotherapy ultimately, but they're meant to be clever. And what they do is they come into the receptor, they get sucked into the cancer cell, they release their chemotherapy within the cell, and dead cell. And so that's how these ADCs work. We do have this really interesting study coming called EvoPAR, looking at a brand new PARP inhibitor called saruparib, and that's being broken down into patients with BRCA mutations and patients that don't have BRCA mutations, and that these are all patients who have had PARP inhibitor before, so this will be the second line PARP. So we should hopefully have this open after the summer. And then just to finish up, I had just wanted to flag a couple of supportive resources. That this is go.ie website is incredible and should absolutely be something everybody should go on to. You can create your own personalized I suppose resource within it. So put in as much information as you have on yourself, and it'll be able to tailor what is more relevant to you. And obviously they have continued public and patient involvement. Keating.ie obviously. Overcare.ie is also, they have, I've spoken to them a lot, and Sharon O'Toole in St. James's Hospital drives this. They do a lot of ovarian cancer awareness, as well as the Dip or Dive, and they do things for World Go Day. And then obviously clinical trials are available on cancertrials.ie. Thank you very much.
Thank you so much. I deliberately read out your bio, Dr. Collins. Everybody needs to know, like, we have such an expert here in Ireland, and so passionate, and we all know this is ovarian cancer is one that we do need more research, more treatment, and look, You're not going back to the Royal Marsden, okay? So it is coffee time. Coffee time. Let me see if I can get us back up here. So anyways, I don't need to bring it back up, but we're going to have a quick break. If we could be all back at 11 for the first speaker up, and just try and get my mic down here, is Advanced Nurse Practitioner, Susan Walsh. Susan is an ANP working in breast care service in Cork University Hospital since 2020. Susan previously worked as a clinical nurse specialist within the breast check screening service for almost 7 years. Her role primarily within the ANP-led breast family history service, reviewing patients with a strong family history of breast cancer and those patients confirmed with genetic alterations. She also works within the consultant breast surgeon clinics, reviewing patients with new breast symptoms, as well as those patients attending cancer follow-up clinics. Most recently, Susan has organised a community cancer awareness educational evening, fellow ANP colleagues with fellow ANP colleagues in various cancer settings. No, start again, Bernie. Fellow ANP colleagues in various cancer settings assisted in delivering education to improve public awareness of cancer and encourage lifestyle behaviour changes. And that's fantastic. Education awareness is so important. Susan is going to present on care pre and post risk reducing double mastectomy. And up you come, Susan. You bring the water.
Thanks, Bernie, for that, and thanks very much for inviting me here to speak today. I must say I feel like a very little fish when I see the lineup of speakers. I'm going to just talk to you. I suppose when I was chatting to Bernie about the brief for the talk today, I really wanted to find out what did people want to know about, or what aspect to go with the talk. And from the WhatsApp group, Bernie was saying breast cancer awareness and the management, I suppose, pre and post surgery is really where the focus needed to be. I'm not going to discuss various reconstructive procedures because we have a much more qualified person speaking after me about plastic surgery. And so it's really just about, I suppose, how to mind yourself before surgery and how to mind yourself after surgery. I suppose I meet an awful lot of women in the clinics every day between the 3 different areas I work within, and I do ask when I'm talking to them, do you examine yourself regularly? And the vast majority of people don't. And the most common comments that people would make is that they don't know how to examine themselves, they don't know what they're feeling, my breasts are lumpy, or they're afraid to feel in case they find something because they don't know what to do. I suppose I put up just the anatomy of the breast so you can see what you are feeling to give it a bit of context. One of our consultants has a great analogy for describing breast tissue to a patient. If you can imagine a bunch of grapes and the grapes are small and close together, that's your glandular tissue. So when you're feeling your breast and you're feeling bumpiness, that's part of the reason you're feeling bumpiness, is your normal breast gland. Some of us have more fatty tissue over a gland and some of us have less. And as you get older, the glandular tissue becomes less and you develop more fatty tissue, so your breast gets softer. The natural aging process takes in and your breasts droop a little bit more, and they become a little bit easier to see on imaging. So I suppose that just hopefully provides a little bit of context as to what you're actually feeling when you are examining your breasts. There's no right or wrong way to do it. The most important thing is you're doing it. They're yours, so they're your responsibility to know what they feel like. In terms of examining yourself, if you see the first picture where it says, how do you do a breast exam? Ideally, that's the way your hand should be, flat against the skin, as opposed to pinching the breast tissue. Do you imagine pinching, you're going to feel lumps? Whereas if it's flat, you're kind of squishing out the breast tissue and you will feel if there is a true lump there or not. There's no, as I said, no right or wrong way. The first of the month is a good time frame to remember. If you're having regular periods, about 7 to 10 days post your period is the easiest time to examine your breasts. But I said, don't overthink it, just do it. Do they feel the same as they did last month? It's as simple as that. If they don't, what is different? Go to your GP or contact your nurse specialist or your advanced nurse practitioner or whoever your point of contact is in the clinic. I would hope as the BRCA mutation carrier that you do have a point of contact, that you can link in quickly and easily with someone to answer questions in the breast services. And I suppose if you don't, make it your business when you go to the next clinic to make sure you have a nurse that you can link in with, or a secretary or one of the team, because it is really important to have quick access because you are at a higher risk of developing a cancer. So you do need that reassurance and that connection if you're within the breast services. You'll see in some of the pictures that the arm is stretched. The reason for that is that you're stretching the chest wall muscle away from the breast tissue. So again, it makes it a little bit easier to examine. Doesn't matter whether you do it standing up or lying down, it's really what's most comfortable. Some people find in the shower is a little bit easier with the soapy hand. Again, then the last picture, you see a woman standing in front of the mirror. We do ask you that you do have a look at what your breasts look like, because there are some changes that you won't feel, but you will see visibly. And I do have a few pictures coming up of symptoms that you should be, I suppose, looking out for. In terms of what you are looking for, it's a new lump, a lump that doesn't go away. Usually it's a painless lump. Painful lumps are usually representative of breast cysts, which are fluid-filled. They can come and go, very much linked with hormonal changes within the breast, linked to your menstrual cycle, your menopause, pregnancy. But any new lump, you should get checked out. Any change in the skin, so a puckering or a dimpling in the skin, and I have a picture of this in a minute just to show you what it does look like. Often that can be something completely normal, but when we do see it, we do get a little bit concerned. Is there something growing underneath the skin that's pulling the skin inwards? And that's one of the symptoms we do say get checked out. Any new nipple changes, so a nipple turning inwards, particularly if it stays inwards and it doesn't pop back out again. Again, the normal aging process in the breast, the ducts behind the nipple can shorten and fatten and can sometimes pull the nipple in, quite normal, but any new nipple changes you should get checked. Any new discharge or fluid from the nipple, particularly blood stains, any new lumps in the armpit area that don't go away, or a visible change in the breast shape and size. So whether it's an increase in size or suddenly it's gone a lot smaller, it's not unusual for a woman to have one breast slightly bigger than the other, and that's normal, but it's a new change is what we're talking about when we talk about breast changes. And if you do notice a change, is that go to your GP, link in with your contact in the breast service, and you'll get seen an image, and the vast majority are for benign, normal reasons. So when you talk about breast lumps, sometimes they are as visible as this. Between those two pictures, you can see that it's protruding from the skin, but a lot of the time they're deeper in the breast. And again, most lumps are completely normal. You can have a cyst, which is your fluid-filled. You can have a fibroadenoma, which is a little ball of breast tissue, completely benign. And obviously then small hard lumps can be representative of a cancer. So they're the ones that we would investigate even more, but all of them need to be checked out. I suppose it'd be remiss of me not to mention breast pain, because this is what happens to every woman, and this is what brings a lot of women to their GP. Breast pain for us is not a concerning feature. It's usually linked to hormonal changes within the body, such as your period, pregnancy, menopause. It can be a sharp shooting pain. You can get a fullness in the breast, and it comes and goes, and it happens roughly the same time every month. That's your cyclical mastalgia or your cyclical breast pain. Some people would have it at any time of the month, and that's your non-cyclical breast pain. Again, not a concerning feature for cancer. There is a capsule called even primrose oil, or starflower oil is another one. It's a natural supplement that can be very good to help reduce that. But the key with it is that you do need to take it every day, and you do need to take it every day for 3 months to see if it's going to be of benefit, not just when you get the pain. It doesn't work like that. In terms of nipple retraction, so that's where the nipple is turning inwards and it stays inwards. There's just an example of pictures of that, so you can see what it looks like. And this is what we're investigating. Is there something growing underneath the nipple, pulling it inwards? It can be, again, a benign growth, but sometimes it can be a small cancer, so that's why we should get it checked out. The peau d'orange is that orange peel skin you hear talked about. Not very common, but I just said it is good to see a visual representation of what it looks like. And as you can see, it very much looks like the outside of an orange. The skin dimpling. So there's 3 pictures. The middle one is the most obvious, that you can really see that dimpling in the skin. The 2 outer ones are quite subtle, and it can be hard to see this, but this is why we do say, please look at your breasts in the mirror. Because if there is a change of that, you might not necessarily feel a lump, but you should get something like that checked if it persists. And then a persistent rash is often another, it's not a common symptom, but and more often not, it's a skin-related issue and not a breast cancer-related issue. But your GP will recognise when it's time to send you to the breast clinic. They will try certain topical ointments first. And with your history, they're going to probably send you in anyway. But it is worth, if the rash is persisting, make sure you get your GP to check it out. So when we talk about breast cancer, we talk about risk factors. We talk about non-modifiable risk factors and modifiable ones. The non-modifiable ones are the ones you can't do anything about, but you still need to know about them. Being a woman and getting older are your biggest risk factors for developing breast cancer for the general population. Obviously, when you have an inherited genetic mutation, that is your biggest risk factor. Dense breasts, I'm just going to mention it because it's one that comes up an awful lot in conversation. The younger you are, the more dense your breasts are. That is normal. Dense breast tissue is more glandular tissue, less fatty tissue. As you go through the aging process with menopause, your breasts usually become less dense. So basically what it means is on a mammogram, when they're looking at the mammogram, they can see through the breast tissue a lot easier. It's not so much white coming up when your breasts are less dense. When you were younger with an inherited mutation, this is why we do MRI surveillance, because your breasts are dense and the MRI is a better modality in that scenario. Lifestyle changes is one we speak a lot to the general population about, and how that can reduce your risk of cancer in general. They predict that almost half of all cancers are preventable through our lifestyle and behaviour changes. When you have an inherited mutation such as the Brca gene, there is no definite scientific evidence to link lifestyle changes to reduced risk of breast cancer. At the same time, lifestyle changes are important for your overall health, your cardiac health, your recovery post-surgery, and reducing your risk of other cancers. We should all be exercising approximately 150 minutes of moderate exercise a week, not consuming excessive amounts of alcohol, so not more than 2 units of alcohol a day, not smoking, and maintaining a healthy BMI, particularly a BMI less than 30. And that reduces your risk of just other health complications. And particularly if you're facing risk-reducing surgeries, your lifestyle is very important in your post-op recovery. So I suppose that brings us to the management of a patient with the Brca mutation. And there's probably plenty in the room that are living with this news a long time, so this might be old news to you. But I think it's just to bring you through the different steps so you're aware of where we're, I suppose, coming with the advice on what should be done. We follow the NICE guidelines in terms of family surveillance, and I have a link at the end of the presentation with the name on it, that if you do want to look up and see where we're getting our information from. And it's all research driven as to what is being practiced. There's intensive surveillance in terms of MRI and mammogram, and I'm going to go through them all individually in a second. I'm not going to discuss risk-reducing surgeries, as I said, but that does come up in discussions with regards to ovarian cancer and removal of the breast. And then chemo prevention is also on the table for discussion. Chemo prevention is essentially anti-estrogen medication that is used to reduce the risk of cancer development. There's no significant or no proven benefit for reducing your death from breast cancer by taking this medication, and it does come with a number of side effects which need to be taken into consideration. It's not commonly prescribed, but it is important you're aware of it and that you can have a discussion about it. And the NICE, I suppose, guidelines have a decision aid for patients to help you make a decision whether it's something you want to consider. They estimate in 1,000 premenopausal women with a high risk of developing breast cancer. For those patients that take the tamoxifen for 5 years, there'll be about 30 cancers prevented. But 70 women who take that will still develop a breast cancer. Side effects, there are a number of side effects, and I suppose this is what does deter women from going on it. Commonly, it's menopausal symptoms such as hot flushes, night sweats, vaginal dryness. Less commonly, but more serious, can be endometrial cancer, clots in the legs, cataracts. So it is one that needs serious consideration if you're going to go down that route. If you're in a younger age in your family planning, you do need to be offered for a couple of months before embarking on a fertility journey. And it's not recommended for women with the BRCA1 gene alteration, because the most common cancers that are associated with a BRCA1 gene are hormone negative, so not driven by hormones. So there's no benefit in reducing or blocking your hormones if your cancer that's going to develop is not driven by hormones. So you'd have the tablet with all the side effects for absolutely no benefit. As I said, it's not commonly prescribed, and from speaking to other NP colleagues, that's kind of a national consensus. In terms of breast surveillance, I suppose it is important to state that it does not prevent breast cancer. The whole purpose of regular intensive breast surveillance is to detect breast cancer at an earlier stage, and so you have an earlier diagnosis. We do follow the NICE guidelines when it comes to breast surveillance. The MRI is recommended from 30 to 49 every year. If a lady presents with a BRCA mutation to our service from 25 onwards, the advice from the genetic services is that we should be doing a yearly risk assessment at that stage to see if the 10-year risk is going over 8%. And there is a role for commencing MRI surveillance at that stage. At 50 onwards is when MRIs would usually cease. We would review the woman's breast density at that stage, and if they're still considered quite dense, then we would bring the case to the multidisciplinary meeting and make a decision as to whether we should continue MRIs, and that's usually reviewed on a yearly basis with the aim to stop as soon as the breast density reduces. In terms of mammograms then, it's a yearly mammogram from 40 to 69. Again, we sometimes will commence this earlier from 35, depending on the presentation of cancers within a family and the age of that diagnosis. And ideally, we try and space the MRI and the mammogram if you're having both, if you're in that age category, we try and space them out 6 months apart, so you're having some form of imaging every 6 months. Obviously, pregnancy delays any of this imaging. We don't image during pregnancy at this point in time. But we're still there, we still do the clinical exam. If there is any symptoms, we would organise an ultrasound assessment and see what's needed from there on. So that brings to the post-risk reducing mastectomy few slides. So the lifetime risk of breast cancer does reduce if you have your risk reducing surgery by about 90 to 95%. And this, the next sentence is one that causes huge angst within the Brca population about no longer needing mammography or MRI screening, but it's because there's very little breast tissue left to actually image at that stage. And whether you have a mastectomy with no reconstruction or with reconstruction, we don't do any MRI or mammogram imaging. And that is, from speaking to them, that's very difficult because you've gone from this intensive surveillance, this intensive imaging, to then being told you don't need anything. But any residual breast cells are directly under the skin, so if you're going to develop a symptom, it will be palpable, you will notice it. And then we would do an ultrasound assessment and a workup at that stage. The initial post-op care and follow-up is per your plastic surgeon and your breast surgeon, and that varies depending on the type of reconstructive procedure you have and the consultants you're under, so I'm not going to discuss any of that. Prior to doing this talk, I just linked in with the AP colleagues around the country to see what are the practices in every unit. And so the consensus is that patients are discharged after a certain period of time from the clinic. The time frame varies, certainly there's no standard, and again, it comes down to consultant preference and the patients that they're dealing with, and it's personalised to that. And again, the discharge from clinic is a very unnerving time. You become very vulnerable again, and we're very aware of that. And I suppose this is where I would say, make sure you have your contacts, whether it's the breast secretary, the A&P, the CNS, one of the team, that you have someone to link back in with directly. So although you're discharged, the door isn't closed. We're there still in the background, but I suppose discharging means you're moving on in your journey, and it's important that you can move on without all the hospital appointments and try and get back to life without hospital appointments from that perspective. Regular breast awareness should still continue in the same way that it should continue for every single woman in the general population. What you're looking for is very similar whether you've had a mastectomy with no reconstruction or with reconstruction. You're looking for any new swelling or lump on the chest wall. And it's really important to get familiar what your breast, whether it's the mastectomy site or the reconstructive breast, feels like after surgery, because you're going to have surgical changes, you're going to have scar tissue. And again, if you're familiar, you will notice what a new change is. Any swelling or lump in around the armpit area, particularly radiating towards from the edge here out to the armpit, that's your axillary tail. Sometimes that is where a breast cancer will come back or develop if you're going to have a breast cancer. Any swelling or lump in around the collarbone, and again, any change in the skin texture, such as puckering or dimpling. So exactly the similar symptoms that you would have been doing before you had your surgery. You can, if you've had a reconstruction, you can have changes in the years after reconstruction that can be linked to an implant change. And again, these should be reported, and you get imaging based on that. They'll often do an MRI to check the implant to make sure it's okay, but you can get a change in the shape of breast size, similar to the picture that's up. You can have a swelling of the breast, persistent breast pain or tenderness, or hardening of the breast. And so what they're looking for in that context is, has the breast implant ruptured, or has the tissue around it gone really hard and kind of contracted around the implant? And they are things that you should be reporting as well to your GP or your breast clinic. The main message, whether it's pre or post surgery, is report new symptoms to your GP, to your consultant breast surgeon, or to your point of contact within the breast clinic. And then breast imaging will be directed depending where you are on your journey. And that is going to be the talk for today. I suppose just to leave with the message that if you have not been affected by cancer and you are a Brca carrier, it's a diagnosis of risk. It's not a diagnosis of cancer. And I hope that from today's, all the different talks you realize you have a lot of healthcare professionals willing to support and help you through this journey. And it's easy for us to discuss all this. We're not the ones with the Brca mutation, but just know that we are there to try and get you through it as much as possible.
very reassuring, and great information there. Thank you so much. So, moving swiftly along, I'm just going to introduce this. I think we'll come this way just in case we have another. I'm going to introduce Ms. Jemima Dorairaj, and then we're going to switch over computers. So we'll just need a second or two in between. So Ms. Jemima Dorairaj is a consultant plastic reconstructive and aesthetic surgeon who is fellow of the Royal College of Surgeons in Ireland and a member of the Irish Association of Plastic Surgeons. She is fellowship trained at Peter McCallum. We have that in common. Well, not that I trained as a fellow, but we work together. I work there as well, lovely spot in Melbourne, and also St Andrew's Centre for Plastic Surgery in Chelmsford in the UK, and also the Royal Marsden Hospital in London. Her subspecialty interests include microsurgical reconstruction of the breast and head and neck, in addition to skin cancer surgery. She also has an interest in breast and body contouring surgery. She currently practices in the South Infirmary, Victoria University Hospital, and in Cork University Hospital. So looking really forward to Ms. Jemima's presentation, and we're going to hear a lot more about reconstructive surgery. So we're just going to switch over computers here. Flip out. That's perfect. Thank you. Thank you very much. Thank you very much, Bernie, for the very kind introduction, and for the seminar organisers for this invitation to present to you today on reconstructive breast surgery. So as part of my talk, I will discuss the breast itself, its significance, and the plastic surgeon's perspective of what beauty within a breast is. I will talk about the aims of reconstruction, and the vast majority of my talk will look at breast reconstruction techniques. There'll be a lot of information that we'll be imparting today, and ultimately there'll be factors that you'll be looking at when considering what your options are specifically for reconstruction. I will also briefly touch on nipple and what your options are from that perspective, and where you go from here once you've decided that you'd like to go ahead with a prophylactic risk-reducing mastectomy. So in many cultures, the breast is a potent symbol of femininity, beauty, motherhood, and vitality. I mean, it's not surprising that losing a breast can be psychologically distressing. Many studies have shown that patients who've had reconstruction post-mastectomy have less anxiety and depression than having a mastectomy alone without a reconstruction. And therefore, there is a push to have an immediate reconstruction post-mastectomy. There are 4 important parameters that we look at that we feel define the beauty of a breast, and some of it is very obvious and self-explanatory, but it's to do with the location of the breast on the chest wall itself. Anything that's too high or too low will seem imperfect. What you want is for a breast to be proportionate with the width and length of your torso. It needs to, of course, be aesthetically pleasing in shape, and what we look for is for the outer border of the lateral border of the breast to be just outside your lateral chest wall. For most of your fullness to be in the lower outer quadrant with the least fullness in the upper medial quadrant. And when you look at it from the profile, you want it to be almost a straight line or slightly sloping or concave from your clavicle to your nipple. You also want it to be symmetrical, of course, in volume and in shape. And when it comes to volume, it's often a patient preference and down to the culture that you're brought up in. So when your breast surgeon talks to you about mastectomies, there are different approaches that are used. You would either go for an inframammary approach if you're deciding to keep your nipple, or if in fact you do decide you want to take a nipple along with the mastectomy, the incision is made around the areola itself. And as part of the mastectomy, your breast surgeon would remove the breast tissue and the fat that's related to the breast, leaving the fat that sits just underneath the skin. So it's a very specific plane that we're looking for in order to remove as much breast tissue as possible. And of course, without saying, you know, once all that breast tissue is removed,
It's impossible to recreate a replica of the breast that you've lost, but we would certainly aim to recreate a breast that looks acceptable both in and ideally outside of a bra. We're born slightly asymmetrical anyway, so we're creating sisters, not twins. We want to ideally create breasts that are proportionate, once again, to your body shape and size. And of course, we'll take into consideration what the patient's desires are from the point of view of your size. For example, some women are just generally big breasted and have always wanted to be slightly smaller, for example. Some might want a firmer feel to the breast versus a softer, more natural feel to the breast. We'd also find out, what sort of a reconstruction you want, whether it's something you want right now that will do you for the moment, given your stage in your life, or whether you want something that's going to last you a lifetime. So when we talk about breast reconstructions and what your options are, I like to divide it into three. You've got your implant-based reconstruction, which can be placed either in front or behind the muscle. You can have purely an autologous reconstruction, so that's utilizing just your own tissues to reconstruct the breast. And I'll speak to you in a bit more detail about the different types of reconstruction here. And you can have something that's somewhere in between, where you use some of your own tissue, typically the muscle from your back, along with an implant. And as you can see here, based on the schematic diagram, moving from left to right, the operations become more complex in terms of the technique itself. The recovery is a bit more complicated from left to right. However, the reconstruction is more durable the more complicated the reconstruction you get. So starting very far off on the left with the simpler option, we talk about implant-based reconstructions. The implant that's placed is made out of silicone with an outer silicone shell and a gel consistency on the inside. So if you cut it in half, it doesn't flow everywhere. It's quite a firm silicone gel. And it's been used for decades for both aesthetic and reconstructive purposes. After a mastectomy, more often than not, the reconstruction is done in one stage where the permanent implant is placed into the space that's been created post-mastectomy. However, if the skin is a bit dodgy at the end of the mastectomy, if you're concerned about the viability of the blood supply to the skin, we might decide to do the operation in two stages. So as you can see in the diagram on the right-hand side here, a balloon type of an implant or a tissue expander is placed just underneath the chest muscle. And that's inflated over a course of weeks before a permanent implant is placed in its place. And that usually is a number of months later on. So I mentioned briefly earlier on, you can place some implants in front or behind the muscle. So placing it underneath the chest muscle. So this is the muscle here. And you've got the overlying skin, your chest muscle, and that's the implant that's placed underneath it. That would be a classical approach to how implant reconstruction is done post-mastectomy. It provides good coverage for the implant, therefore, you've got reduced chances of having implant extrusion or an exposed implant after the operation itself. The issue with it is you were lifting the muscle up, you're creating a bit more dead space to place the implant in, and therefore it can be associated with some pain and discomfort after surgery in comparison to placing the implant in front of the muscle. You can also get what's called animation deformity. So as the chest muscle moves, the implant may move along with it as well, which is not particularly a bother for patients in items of clothing, but if you were to wear something slightly light on the top and you're doing weights, for example, it might move a little bit. So the other option, which has undergone a bit of a renaissance more recently because of the better techniques that I use, better implants and mesh technology that's now been developed, is to place implants in front of the muscle. So we're leaving the muscle where it is. We're literally just placing the implant underneath the skin and small bit of fat that you have that's covering the implant. And that implant is held in place with a mesh that integrates along with your soft tissues. It's suitable more so for patients with smaller breasts, so if only less than 500 grams or so is taken out as part of the mastectomy, on patients with minimal drooping of the breast, called grade 1 or 2 ptosis. It's preferred more recently these days because it's associated with less pain. Once again, you're not lifting up the muscle, and it's associated with shorter recovery as well. Early studies show comparable results when it comes to scar tissue that forms around the implant that Susan Sarah briefly mentioned earlier on. And it's not associated with animation deformity because you're not placing the implant underneath the muscle. Because, however, the implant is placed directly under the skin, it might seem a bit visible in slimmer patients, and therefore you might need a bit of lipofilling down the line to help thicken the soft tissue envelope and to hide any contour defects that you might not like. So to summarize the pros and cons of implant-based surgery, it's a quick operation, lasting 2 to 3 hours or so, with a short hospital stay, usually out by about 2 days. You don't have any additional scars because we're literally taking the implant out of a box and putting it into the breast. Cons though, with wounds, you have the risk of infection, and infection around an implant can be really devastating. That may lead to implant removal. Patients do say that the breast feels cold. You can get capsular contractures that form around the breast. So that's when scar tissue forms around the implant. The implant itself is a foreign material, so your body tries to form a wall of scar tissue around it. In most patients, it doesn't cause any problems, so your breast still feels quite soft at the end of it. However, in a small proportion of patients, generally less than 10%, it forms a firm scar tissue, which can start to make the breast look abnormal, feel abnormal, and can also sometimes be painful. And it's for those reasons that you might need revision surgery down the line. Implants can also rupture, they can ripple over time, and it can also move in terms of its location. We spoke briefly about animation earlier on, and I suppose I always tell patients who have implants, they're not for life. And for these reasons that I said to you earlier, they might need to be changed out maybe in 10 years. They might not cause any problems, but more often than not, you might need to have further surgery down the line. I will mention on a condition that's been recently described associated with implant placements. This is an entity called breast implant associated anaplastic large cell lymphoma, and also a different entity called squamous cell carcinoma that's been recently described. Now, it was only diagnosed in 1997, and it's thought to be linked with breast implants with a roughened surface. So if you look here, this is a rough or textured implant, and this is a smooth implant. There were specific implants that were made by a company called Allergan that were very textured, very coarse. And the reason why they were coarse was to minimize the risk of that scar tissue I was talking to you about. And what they found was this condition called ALCL that was linked to these textured implants. It's an uncommon cancer of the immune system that's located within the scar tissue around the implant itself. The incidence varies depending on where you live, and it's thought to be related to a genetic makeup of the population itself. But in Europe, it's thought to be 1 in 300,000 or so. There have been no reported cases of this in Ireland, but patients would typically present with swelling in one breast compared to the other side, generally at around 8 to 10 years after the implant's been placed. Usually, there's fluid around the implant, fluid that's aspirated, and that's how they diagnose the condition. And the treatment for this is to have the implant removed, the capsule removed, and you may need chemotherapy to treat ALCL. Implants are still used, and it's still deemed to be safe, but we only ever use smooth implants these days. Okay, but it's just something that patients are counseled about, because obviously with your overall risk of breast cancer in the first place, it might be something that you really do not want to consider given the small link with ALCL. In last year, they've now discovered a squamous cell carcinoma linked to implants. We still don't know very much about it. And, you know, I suppose it's just a matter of time when we know whether or not this is going to be a major issue down the line. So these are examples of implant-based reconstructions. The photograph on the left is a patient who's had implants underneath the muscle. She's very slim built, and you can still see the shape of the implant. Her nipples have been sacrificed as well. The middle photo is a photograph of a patient who's had a breast reduction first because she was hell-bent on wanting to have implants, and we can only put, 800 cc's is generally the biggest implant that you can put in. So she had to have a reduction first, and then the implant replaced. As you can see here, she's fairly early after surgery. She's still got a drain coming out from her right breast, and her wounds are still fairly fresh. She's still got a bit of excess skin around the implants, which will need to be trimmed later on. And the photograph on the furthest right is a prepectoral implant. So it's an implant that's placed in front of the muscle. And as you can see, it achieves good symmetry to an existing breast. So it does recreate a very reasonable breast shape. In this situation here, she's got a bit of fat coverage over the implant, so it's unlikely she would need lipofilling down the line. We'll then move on to autologous reconstruction, so that utilizes your own tissue. And this diagram here just highlights the different areas that we can take tissue from. For example, the back, the tummy, the flank areas, the buttock, and the thighs. It's a technique that utilizes your own tissue to reconstruct the breast. and the tissue is taken with its own blood supply. If we don't detach the blood supply, it's called a pedicle flap, and the typical area we take it from is from the back, so your latissimus dorsi flap. And if we do detach the blood supply and reattach the blood supply underneath the microscope, that's called a free flap. And I'll go through these in a bit more detail in the next few slides. So firstly, the latissimus dorsi flap, so that utilizes skin and muscle. Often if you are, for the purposes of risk reducing surgery where no skin is removed from the breast, we can omit having to take skin from the back. So we're literally just taking skin and fat from your back. That's then swung forward based on its blood supply into the breast area. And you're left then with a scar on the back, which is what's used to harvest the flap. The pros and cons, as you can see in this table here, are a bit of a mixed bag. It's longer than an implant, so that would be a con, but the pro is that it's shorter than the free flap surgery, the microsurgery, with an operation lasting in around 6 hours still. So it's still a lengthy enough operation. If we just recruit the skin and, the muscle and fat from your back, we might not need an implant, so that would be a pro. However, quite often we would still need to put an implant in to get the volume that you're looking for. So you therefore have the downsides associated with an implant once again. You're in hospital generally for about 5 to 7 days, and that's just because you're discharged, because you have drains that are in place. And quite often you're still discharged with the drain, because this area in the back often continues to drain fluid for a good 2 weeks after surgery. As I mentioned, you have an additional scar on the back in addition to the scars on your breasts. Because the fat and muscle are harvested from your back, it can be hollowed out a little bit, but if you're having it done on both sides, it still looks quite symmetrical. You can get seroma, which is when fluid accumulates in the dead space in the back after the drain is removed. And that's just fluid that we need to help drain in the initial few weeks until your body is able to cope with the additional fluid and reabsorb it itself. So if you have a bit of a water balloon sensation in the back, we stick a needle into it in the outpatient clinic to drain that additional fluid after surgery. And because the muscle is still attached to the nerve that's taken from the back, that muscle can still twitch as well, because we keep the nerve intact to avoid the muscle wasting over time, so you don't lose volume from the point of view of the reconstruction. So pros and cons with an additional scar on the back. And this here is an example of a latissimus dorsi reconstruction without an implant. So skin and quite a bit of fat was harvested from this lady's back. Now the lighting is quite bright in here, so you can't really appreciate the scar, but it literally just sits right there, just here. In this situation, she's only had an LD on one side. And I think it's handy when you see it compared to her other breast, because it does give a good, reasonable result. And if you can imagine having both sides done, you'll have a really good symmetrical result. The downside is the scar on the back. Moving on now to my favorite operation, the free flap or the DF reconstruction. So the free flap, as I mentioned before, utilizes its own tissue that's transferred to the breast with its own blood supply. The commonest donor site where we take the tissue from is the tummy, and that procedure is called a DF reconstruction. The deep inferior epigastric perforator flap. So in a nutshell, we're taking skin and fat from the tummy area. It's harvested along with the blood supply. We have to dissect through the muscle, your six-pack muscle, in order to get a bit of length on the vessel, which is then detached here at its source. The tissue then that you can see here, along with its artery and vein, is then reattached to blood vessels in and around the rib area. And that's what gives the volume to the breast, okay? So in a situation where you're having a double mastectomy, in this schematic diagram, the nipples are sacrificed. So you then have a bag that needs to be filled with the tissues. Half of the abdominal tissue that's at the level below the belly button is used. So, sorry, not the, running out of battery maybe. So half of the tissue here, skin and fat, is taken to reconstruct each breast. So one half of the tummy taken up to reconstruct the right, the other half to the left. And here you can see the outline of the vessels that sit behind the ribs. So these vessels that are taken from the tummy area are then connected to vessels then that sit, thank you very much, that sit behind the ribs. And what you end up with is a reconstructed breast. So the volume comes from the skin and fat that's taken from the tummy area. In this situation where the nipple has been sacrificed, the skin from the abdomen is then placed into the space where the areola was. Okay, so that's the outline of the scar that you have. And then you have the other benefit of losing the excess tummy tissue that you probably don't really like anyway, with a scar around the belly button and a scar that goes from hip to hip, quite akin to a tummy tuck, but the scar is often quite slightly higher than a tummy tuck, but usually still hidden within a bikini or underwear. So back to the table here, looking at the pros and cons. The benefit is that you get a natural feeling reconstruction. It feels warm, and that's the first thing all my patients tell me. It feels warm. It ages with you because it's your own tissue. Okay, so if you gain weight, you put on weight in the breast. If you lose weight, you lose weight in the breast as well because it's all your own skin and fat. And you know, breasts age naturally anyway because it's all your own tissue. As I said, it might sag along with time as well. You have the added benefit of the tummy tuck effect from losing any excess abdominal tissue to the lower abdomen. It's a very durable reconstruction. Apart from minor revisions to kind of tidy up little bits and pieces of excess skin here and there, or to achieve better contour, which is mostly for aesthetic purposes, you only generally need the one big operation and perhaps a smaller one down the line. And usually you're discharged within the year and we never have to see you again, which is a good thing, really, I think, from that perspective. You then have the option to then reconstruct the nipple if you decide to take the nipple off at the time of the mastectomy. Downsides of the DIAP reconstruction is that it's a long operation. Reconstructing one breast takes about 6 to 8 hours. If you're doing two, it's longer, up to about 12 hours in duration. We try to work in pairs, so often I work with one of my other microsurgeons to try and reduce the overall operating time. And we also operate in parallel with the breast surgeon. So while they are doing the mastectomies, we start doing the flap harvest from the tummy. Therefore, reducing the overall operative time and hopefully reducing your overall complication rate from a long operation. Of course, with long operations, you've got risks of clots in the legs called DVTs that can travel to your lungs called pulmonary embolus. And with a long operation, because the machine is doing the breathing for you during the general anesthetic, you're slightly more prone to chest infections, for example, because your lung vessels can collapse after. But that's the reason why we try to get you out of bed on day one after surgery. So there's no laying about, no taking it easy. Day one after surgery, you're out of the bed and trying to mobilize around. So we try to limit your hospital stay to about 5 to 7 days. So quite similar to the back surgery that I mentioned earlier on. And it's a long-term recovery compared to the implant, of course. Because we're dissecting through the muscles in your abdomen, the recovery is much like having a C-section before, so you'd have to be protective of your abdominal region for 6 weeks after, not straining the abdomen, okay? Your wounds generally heal within 2 weeks if there are no wound healing issues, and you're back to normal activity by 3 months. I mentioned about dissecting through the abdominal muscles. Sometimes you might need to take a small amount of muscle with it to protect the vessels. If we do, we will put in a bit of mesh to help strengthen the abdominal area. With a bit of muscle that's taken, you can sometimes have the risk of abdominal bulging. The risk of you having bulging that needs further surgery, corrective surgery, is less than 6%. So it's minor enough. You do have the additional scars that you wouldn't have, say, with an implant reconstruction. And the belly button is repositioned as part of closing up the tummy wounds. This risk is there even if you're having a tummy tuck. The belly button can die off because of a poor blood supply to it. If it happens, it just means dressings for a slightly longer period of time. It often heals with a puckered scar that has the appearance of a belly button anyway. The main risk with this reconstruction is the risk of the flap not working. So that's referred to as flap failure, and the chances of it not working is 5%, which is pretty good, I think. So you have a 95% chance of no issues from the point of view of the flap surviving through the operation and your post-op recovery. So these are some examples of cases of DIAP reconstructions. An older lady with slightly droopy breasts. You can see here the abdominal wound. She's had minor wound healing issues, but healed with no issues there. With this diagram on the left-hand side, she had obviously a nipple taken away as part of the mastectomy, but hers was in a cancer case. But it gives good symmetry to what she has on the other side. And it would, if you were getting both sides reconstructed, give a pretty good result. This middle one is risk reducing DIAP reconstruction. So that's been used to reconstruct both breasts, and she's also had nipple reconstructions, as you can see there. If you decide to keep your own nipples, I've put in this photo here on the right. If you decide to keep your own nipples, we use the infirmary area to access firstly the mastectomy, and that's where we place what we call the skin paddles to help us keep an eye on the blood supply to these flaps after your operation. So obviously she's lying down here, so it looks a bit distorted. But what you're seeing here is actually her abdominal skin. So it's a tummy skin, okay? So that's what we keep an eye on after surgery. The nurses, unfortunately, for the first 2 nights after your operation, you don't get much sleep because we're constantly checking it to make sure that it's alive and there's good blood flow into it. If there's any problems with the blood flow, you're quick to get back to theatre. You try to find out what the problem is to try to salvage any problems. But this area here, we can remove when you're getting your further revision surgery down the line. So that's cut out and that's restitched. So all you have is a straight line scar in the crease underneath the breast. So some patients don't have much abdominal tissue. So we look at other areas then to take tissue from. If you have a small A or B cup sized breast, an area that we would take quite frequently is the inner aspect of the thigh. That's called a transverse upper gracilis flap or a tug flap. Skin, fat, and muscle is taken once again with its blood supply, along with a small bit of muscle that you don't need anyway. That is folded on itself to give a conical shape, and that's placed then into the mastectomy defect to achieve a reconstruction. So in someone like a patient like this, who's a small enough breast to begin with, she was probably an A or a very small B cup breast. The scar that you would then have sits underneath the panty line there. So it's about a finger's breadth below the panty line that stretches from the anterior thigh to the posterior thigh here on the left-hand side. So a less favorable scar compared to the DIAP flap because that's nice and hidden. But in someone with a small breast, it's a very good option, especially if you're lacking enough tissue in the tummy area. And of course, if you are having both sides reconstruction, you'll have symmetrical scars on both sides of your thigh. Now, what if you don't have enough thigh tissue? Other areas then you can still harvest are the lumbar artery perforator flap. So that's in the flanks, your love handles. That can be recruited as well. Some people recruit tissue from the buttock area. So that's called the S gap or the I gap. Now, the Brazilians would never get you to touch their bottoms, but some people would be happy to have tissue taken from their buttock area. These aren't my preferred areas because I think they are associated with a lot more technical issues that can potentially go wrong. And I still have the preference for harvesting tissue from your tummy because I still think the donor sites are by far the best. So I've gone through a lot now at this point, and you're wondering, oh my God, where do I start? What are my options really? And the reality is, all these options are not available to every patient, okay? And that's the importance of having that consultation with your plastic surgeon. What options you have in terms of using your own tissue depends on your body habitus. Where do you have excess tissue? Where can we take tissue from? As I said before, we always take into consideration patient preferences in relation to the size, feel, durability, and where you are in your stage of life. You might have small kids, you can't take time off work, you're the sole breadwinner of your family, probably an implant is better for you. But we can always revisit then the reconstruction down the line. We also take into consideration your cancer history. Of course, some patients with mutations may have had a brush with cancer, and therefore any prior treatment such as radiotherapy can impact what we would offer. I'm less likely to offer an implant-based reconstruction for someone who's had radiotherapy before. Smoking status is a big deal, particularly because this is a semi-elective operation. If you want to consider an autologous reconstruction, cut out the smoking altogether. You'll be doing yourself a favor. A BMI is something that we look at as well. The higher your BMI, that was previously mentioned, the higher your BMI, you're more likely to have post-operative complications. So we might encourage you to reach a particular target weight before going down the route of autologous reconstruction. If you have had previous abdominal surgery, it might impact your ability to use your tummy tissue for a breast reconstruction. And of course, we look at your medical conditions as well, because you might be a high anesthetic risk to begin with, and it'll be daft to put you through a 12-hour operation if you have a high risk of anesthesia. So we then move on briefly to nipple options. If you keep your nipples, it's a no-brainer. We don't need to talk about anything here, but if you do decide to have your nipples removed at the time of your risk-reducing surgery, simplest option to replace the nipple is to put a prosthetic nipple that you can buy online. The options are to also have 3D tattoos, and this is, I pinched this off a company in Dublin, I think, that do 3D tattoos, and I know a few tattoo artists that do them here in Cork as well. Then the breast still feels flat, so you don't feel the prominence of the nipple, but with the shading that they do and the different pigments that I use, it gives the illusion of a nipple at the top here. From a surgical perspective, we can offer a nipple reconstruction down the line. So it's a bit of origami, really. We cut into the skin and fat, we fold it on itself such that it creates this prominence here. And this is an early example of a patient that's had nipple reconstruction. So all it does is it gives that prominence centrally. Later on down the line, you then have it tattooed in to give the color that you usually have with the areola itself. So where do you go from here? I mean, once you've made the decision to have a prophylactic mastectomy, your breast surgeon will refer you on to one of the plastic surgeons based here in Cork. Now, for a long time, my colleague Owen O'Brien on the top right was single-handedly carrying the breast reconstruction service, and thankfully, well, along with Jason Kelly, of course, but thankfully we've now expanded our service to include the likes of Miss Suzanne Beecher, who unfortunately wasn't able to join us today. She's now the lead in terms of our breast reconstruction service, and has been a huge addition to the breast reconstruction service here in the CUH. And another colleague of mine, Jason Chatterjee, that's newly joined as well. We all have our different skill sets. We have our own favorite operations and our own preferences in terms of what we offer patients. And ultimately, what is suitable for you will be discussed. We would generally discuss all these options with you, taking into consideration what your preferences are, as well as what would be most suitable for you. When you're reviewed at a plastic surgery clinic, I would strongly advise you to bring a friend because it's a lot of information, a family member, a friend. There's a lot of information that's imparted at the time, and a lot of it can sometimes go over your head. And it's often good to have someone else listen in on the conversation as well, so that you can troubleshoot and have a discussion a bit after the consultation, to then have that second consultation, which will allow you to discuss in further detail and for the questions you might have. And during those consultations, as I said, we'll go through the history, do an examination, and discuss your options. If you're thinking of going down the tummy reconstruction, the DIEP, we would organize a CT scan, because it assesses the blood vessels, the status of blood vessels, and how suitable you are for that reconstruction. And it also helps in terms of our surgical planning to once again reduce the overall operative time. We then would schedule you in for surgery, and it's usually a joint case that's done with the breast surgeons on the breast surgeons list. So it would involve making sure all our calendars coincide, which can be a bit difficult at times, but we would like to have two microsurgeons there at the same time, once again, to reduce your operating time if we're going with a microsurgical reconstruction, as well as the breast surgeons. Now, unfortunately, we don't have access to advanced nurse practitioners in breast reconstruction. We're very lucky to have had a new addition to our services in the South Infirmary with a candidate ANP over there that's specializing in skin at the moment, but we hope to develop our services further by recruiting our own candidate, advanced nurse practitioner, specifically to take you through your reconstruction options, because there's only so much that we can talk about during two consultations with the plastic surgeon, which often we're under a bit of time pressure. So that's something that we're looking into in terms of expanding our services too. We also are looking into developing a breast awareness, or a breast reconstruction awareness meeting, which allows then patients to meet other patients who've had reconstructions. In the UK, and in, when I was working there, you have some patients that are happy to do a show and tell. You can have a feel of, their reconstructions, and you're able to then have the patient element in terms of what they went through throughout their recovery period, and how they felt the operation went. And you'll get an honest opinion from the patients rather than perhaps a skewed opinion from ourselves as the reconstructive surgeon. So I know there was a lot to take in. I've just gone over by a couple of minutes there. And I hope it's given you an overview in terms of what we can do for you from the point of view of your reconstruction, should you wish to go down the route of a reconstruction after your mastectomy. And I welcome any questions that you may have in our question.
Thank you so much. Fantastic overview and all the lovely pros and cons. I think that was fantastic. And I think I should mention show and tell. We will be soon starting planning, as I look at Liz, our CEO here, for our Breast Reconstruction Awareness Day. And we would have ran it, I'd say, for about 3 years, except last year. And that is where fantastic women would show and tell their reconstruction. So we do it together with the Mater. And I believe this year it's not just going to be limited to Dublin. Yeah, bit like today. Don't know where it's going to be yet, but watch out. Keep an eye on the event section. So thank you so much, Jemima. That was fantastic. Really appreciate that. And maybe if we bring up all the morning speakers, Susan and Rosie, and let's see who else. I know Dearbhaile has gone home. Oh my gosh. Oh, Trina, yeah. Doesn't that noise really get your ears? Sorry, guys. We'll just use it. Right, thank you so much, everybody, and thank you. Thank you. Okay. I think that's what you said. Yeah. Need to keep them away. One both hands. Okay, I think that one is. Yeah. Okay. Mute me, as my kids would say. Great. Afraid to talk now. Yeah. I think we're okay. We're okay. Hello. Yeah, I think that's very good. We'll need a second one. So if anybody has any questions, and woo, the hands go up. So you can say who you have the question for. So you know who we've got up here in front of us. We've got Susan Walsh, Advanced Nurse Practitioner in CUH, Dr. Caitríona McCarthy, from the NCCP, Dr. Rosie O'Shea from Genetic Counselor down from St. James's, and Miss Jemima Dorairaj. So
wasn't me, I promise. This is for Miss Jemima. I hope.
Without the mic, I think we can hear you actually.
So sorry. We did get an AV company in, but we'll be sacking them out.
Hi, thank you all so much for the wonderful presentations. You were amazing, especially Ms. Jemima. I was just wondering, I've had the double mastectomy and reconstruction with implants, but I now have capsular contracture, and I'm at the point where it's a case of, do I go again with a new set of implants, or do I go for the DF flap? Sure. And I was just wondering, and I know everyone's case is different, and I know it's a how long is a piece of string question, but if it was you, or say a daughter, a niece, a best friend, or whatever, what would your advice be on where they should go, be it go with the implants again or go with the DF flap?
Yeah, thank you very much for your question. So from the point of view of capsular contractures, the problem is if you've had a capsular contracture once, if you get the implant exchange capsules removed, you could still get another capsular contracture. It's the reality of the situation. Okay, so realistically, once again, it just depends on your overall, situation in terms of your age, your other medical issues, and whether or not you're suitable for DF reconstruction. But say you are, I personally, obviously, it's a bit of a skewed perception, but as I said, I think that DF is an excellent reconstruction. If you are suitable for it, I think you're less likely to need further reoperations down the line. So yeah, I mean, your risk of a capsular contracture, as I said, is about 10% anyway, and that risk is increased by 1% every year the longer you have your implant. So it's constantly increasing as time goes on. And once again, if you've had a capsular contracture once, you're more than likely going to get another one. And the reality is that's where the demand for the service is going to be going to as well. So not only are we catering for patients who are at that point where they're deciding, oh, I want to get a mastectomy done, do my reconstruction immediately, but then you have the revisional issues that we're having to deal with. And I think there's a lack of realization about the resources that are needed to deal with the complications of other forms of reconstruction as well. But yeah, no, it's not an unusual situation that we face, but absolutely, I think a DF would probably be a more long-term solution for you to avoid the need for further reoperations down the line.
Thank you very much. Thank you. I don't think there's any point in.
Yeah.
If everyone is back in your, yeah.
No, I just want to thank you all again for your talks today and for looking after us all. I suppose my question is kind of coming from a genetic space, and as far as I know, the lack of a database collating all of our information and how that could be used to drive policy changes. And I suppose the bit that concerns me the most is the feedback loop. So if there's new genetic information that comes out about a particular variant, how is that fed back to the patient? I know it was shown in the talk today that it's one of the themes that we're looking at, but do we know how far away we are from putting together a database like that?
I can start. In our service, we've got a dedicated database that collates progeny is the name of the database. It collates the information about the clinical journey of the patient, the time, referral, when the person was referred, their kind of demographic information, then what their clinical information, what tests we've ordered, and then what the outcome of that test is. So we've only had that for 18 months. So that's kind of now a clinical database that will help us to drive what you're talking about. I think maybe the cancer registry.
Yeah.
And I think I agree, really important. We need really good data. We don't have good description of how many people in Ireland there are who have genetic variants in different genes. Now there's more genes that we're finding. So we're at the start of that journey clinically, collecting that information, building out that database. But what we do need is that kind of infrastructure, for building a registry for long-term follow-up and care for what we were describing. When new genetic information comes back, there's a really good example of this in Keating in Australia, where they've done a longitudinal clinic is probably the word that's coming to mind, but it's not actually called that, where they're recontacting patients when there's new gene, new information about a variant. But the way they've done that is by having the baseline of data, allowing them then to recontact patients in a timely way when there's new information. So we're on that road to try and build something that allows us to follow up. But our challenge is the resources that are needed from a genetic counselling perspective then to ensure that we can provide follow-up and long-term care. But that's where we sit in, where I would like us to sit in cancer genetics, is in that survival space where we have people that we know who have a variant that's not defined, or people who have a genetic defined hereditary cancer syndrome, or family history that needs follow-up. We're providing longer-term follow-up care. But at the moment, we're kind of at this front end, getting access to the testing, ensuring that patients get the proper genetic counselling, and then the results and management. But in 5 years' time, I hope we're moving into that other space, and maybe training can talk a little bit.
Yeah, the other thing I'll add really is maybe, looking across the water in the UK, I think with Lynch syndrome, they've sort of gone down that track, trying to have a Lynch syndrome registry for the country, and absolutely the things you're saying in terms of it's not just, it's partly the management for the patient themselves. So when I was talking about that whole recall system, we have that same population screening, but, you know, having a cohort of patients, a group of patients who have the same needs, you know, being able to use that at a sort of a national level to help and aid their management and look at things such as how many people have surgery or don't have surgery, you know, being able to know those things and, and plan them, you know, and, you know, I would like to know, if I had BRCA, do most people in Ireland have surgery, don't they? Or, you know, to be, you know, that information even in itself be useful, but also for planning the services and knowing how many people are going to be having these operations or anything in support. So it's good for planning the services, but also for the individual patient. I think looking at the model of something like the Lynch Registry in the UK as well. So that's what I said, it's kind of the resources and trying to at least sort of call out now, what do we want to measure and what will be the most useful things to measure. And then there's always a little bit of, you know, do we do it just for people with BRCA, or do we do it for everyone in cancer genetics, or do we have a registry for anyone with any genetic predisposition? But there are more options than whether or not it's a good idea to do it. I think you're absolutely right, it is.
I could be on my neck one more small question. So,
I know it's
yeah,
I could use one line there and then
spiritual term.
Yeah.
So my testing was done by Myriad Genetics, which is an American company, and they store that data. The US has a policy to own any data generated on their soil. I saw for the new kind of app-based technologies that you're using, that testing will be done in Berlin in Europe. Europe has different GDPR rules, and it is something that my husband works in cybersecurity and I'm a scientist. It does concern me that my very personal genetic information is stored in the US. Is there an opportunity for us to bring that genetic testing into Europe or even within Ireland?
So the national genomic strategy is very much looking at that sort of where are tests going? From Ireland. Most of them are going to different countries because there is a resource of genetics laboratory in Ireland. And their role is to kind of think about, well, what would Ireland need to ensure that the genetic information is retained in Ireland or the EU? Where we're sending actually our testing currently is in Finland, nuclear genetics, so that they're within the EU, all the data protection rules that are in place to ensure that patients' DNA stored and they know what length of time it's stored.
I need to talk.
Sorry, I have to forget a little bit. Can you hear me?
Yeah.
Can you hear?
I'm sorry.
Will I go back?
No, you're doing good.
Yeah.
I'm
Coming back to kind of, good question to think about, you know, where is my data? Where will it be stored long term? Our plan is that will be in Europe and within the EU data field and regulations for what we need to adhere to within Europe. So from the US perspective, it's a hard question to answer. I don't know, will the genomic strategy be looking at repurposing data from other countries? I know that the EU data infrastructure plan is to have a cohesive network of sharing of data in a way that allows different countries to pool their genetic data to understand the genetic basis of a disease. So I think having it in the EU with that protection will be really valuable, but also allowing research to happen, allowing clinical information to happen, so that it's not a barrier for patients and for us to try and, you know, work to do in the future. I hope that answered your question.
Thank you, and
Foods looked great.
oh.
Done good, see my colleagues.
Hi, I don't know who I'm directing the question to, but I suppose while I'm here, I have a few small questions. I was diagnosed with BRCA1 in February 22. I got ovarian cancer in September 21 and stage 3C and 5 grades. As well, when I got the BRCA diagnosis, my family, we all went through America to the Cork. And I have to say, thanks to Lisa and to Barry, they were just, oh my God, a fantastic support for all the family. And I just need to say that the WhatsApp group is absolutely great information and great support from everybody as well. But my diagnosis, my gene didn't go from my mom and my dad. So I was just wondering, is that something that you kind of use, you know, lately, because it's very new, I don't have that much information on it. And secondly is for my two daughters are BRCA 1 as well. And again, it's 2 years. They went through birth as well, but we have had no support from James and all. They are aware of it, but there's no support for them at the moment. And then just real quick, Tori, is there for someone that you have has had ovarian cancer? And I've had chemotherapy and I'm also on the PARP inhibitor, so I was on all the PARP from April to November, but it's terrible side effects, so they stopped it. And I am on the narrow PARP now, which will be 2 years this month, and due to have the next CT scan in the next few weeks. Does it stop at 2 years, or have you had some PARP inhibitor?
I think the PARP inhibitor question, because Dr. Dermot.
Yeah.
I think it's answered.
I can certainly help with the genetic.
Yeah, that's great. Over to you also pass it on as well. And she had to run.
So it can happen, it's rare for BRCA to be in a person for the very first time. I think the more we do broader testing, maybe we'll find a little bit more information about prevalence of BRCA, and usually it's something that you see in hereditary and family. The question about access to testing, it is a real significant barrier, 2 years, and I can see why people look at other avenues to try and get testing in a quicker way. What I would say is if your genetic test result comes back, and so if your children, if they've been positive, they would have had some telephone counselling with a US-based genetic counsellor, but I'd encourage them to be in the Irish system to understand and navigate like what the options are. You know, you're all very aware of that in the room. But what they can do is get a referral back into the system. When we know there's a genetic variant found, that person is seen in 1 to 16 weeks. So
That's what happens 2 years now.
so have they
They are aware, James are aware of it.
they've been referred into
Yeah,
the
and
system
they've had no contact.
and they're positive. Yeah, I wonder, maybe can we chat afterwards and maybe get some details, because it's what we've done now in our triage system is if someone has gone that route because of the access delayed, if we have the variation, then the triage has changed. Yeah. So maybe it's the communication of that triaging we need to sort out. Thank you for your feedback.
Thank you.
And the PARP inhibitor.
I don't think any of us can answer.
No, so
PARP
what we
inhibitor
agreed with Dr. She had to go. She's
Okay.
the one that's fine. So she has said we can take questions and we can submit them to her. So maybe if we link and this is a question more than we are going to. Okay. Yeah. Anybody else? We have to bring you up to the front because we don't want another bang down here burning. Yeah, it doesn't work.
It's a very simple question.
Yeah.
I have 2 children, 13 and 16. At what age would they be genetically tested? See if they have BRCA.
18 plus is kind of the recommended age, yeah, so in the adult years and when they're ready. Because of the access delay, so what I would say is someone, someone is ready and they've had that information, a referral can be made. We are working on different solutions to make that access delay less. You know, that we hope to get to a point where we're 6 months, a year would be ideal, but you know, it takes time to get there. So yeah, if the person's ready and wishing to have that information, a referral before they're 18 is reasonable, but you know, they would wait a significant amount of time. 18 is the age that we would recommend testing.
I'm also like people who maybe I got genetically tested in the States. So do I have to get back into the Irish system? Or do I just figure it out myself, as in go privately or to want to get it?
Many options. So yeah, if someone has private health insurance and they want to access genetic testing, there are a lot of insurance companies now cover genetic testing, and genetic cancers do exist in the private system. I don't work in the private system myself, but that is a possibility for people. So if you have private health insurance, I think that sometimes people get referred into the public system, aren't aware maybe that their insurance covers genetic testing, and they may end up on a wait list. So it's to know that there is the 2 options for people and when it comes to access. Then if you have gone direct to consumer with colour and you find out you have a genetic variant, contact us and let us know that information. We need to see that new information to retriage a person, and they're seen within 1 to 16 weeks with the team that we have now. So that's really important. Update us and we can relook at that.
Any more questions?
I just have a general question, maybe Jemima, you, and thank you so much for your wonderful presentation. It's fantastic to see the different techniques that are available now. But I know from our Brca community, post-COVID, there was a huge issue in terms of capacity, and particularly we were hearing that risk reducing or prophylactic surgeries were being delayed, and that obviously breast cancer patients were being prioritized. So I don't know if you can speak, you know, for the country as a whole, but has that situation now been alleviated, or are things still improved for patients who want to have prophylactic surgery?
Sure. I can only speak for what's going on in Cork, really. I think what's made a huge difference is expansion in terms of our service. So you have more people that can actually do these operations. So there's less demand on, certain number of surgeons who have additional commitments as well. So all of us, we don't only solely do breast reconstruction, we deal with other sorts of cancers, etc. So that's one thing to note there. So I think with I suppose improvement in our staff numbers, it's certainly made a difference in terms of patient access.
Yes.
What we are really limited by is actually theatre access. So I mean, we've had the same number of operating theatres in Cork University Hospital for I think the last decades even, and the reality is, everything is evolving, the number of patients being diagnosed and the population has increased, and there's just the demand doesn't meet what our resources are at the moment. So whilst there's been a slight improvement in access for patients with mutations who want a reconstruction, we're still a long way from where we should be. At one point, my colleague was actually having to refer patients to Dublin because they couldn't cope with the numbers. But at least I think now we can actually somewhat cope with it. We're still doing most of these bilateral reconstructions in CUH. What we're looking to do is we're building a business case to do them in the South Infirmary Hospital because it's a brilliant setup for elective microsurgical reconstruction cases or implant-based reconstruction. But the issue is actually getting it over the line at a more national level with management and that. Because ultimately, money talks and it's trying to get the funding to resource the services. So it is better, it's nowhere near where we should be. And therefore, as a consequence, patients are still on a waiting list, unfortunately. And of course, as I said before, DF reconstruction, for example, it takes a whole day. If everyone goes for an implant, we can do, 4 patients in a day. But if you are going for the Rolls Royce of operations, theatre access is a problem.
And I would just add that if that is kind of the situation across the country, I think just from the plastic surgery program with it was it's really the theatre space that they have. This has been sort of a very niche specialist area, but that the plastic surgeons coming through and that sort of specialism now was there are lots of new appointments that have people that can do the surgery. I think as you described earlier, if you have 2 people operating together, it's better for the patient because they're under anaesthetic for a shorter time, but it also means it's a shorter time in theatre. So you can make better use of your theatre space, but there's still nowhere near enough theatre space in any of the hospitals in the country. There are 1 or 2 that are, Beaumont probably is doing well enough, I think, but I think almost all the other hospitals in the country are screaming out for extra theatre space in general, but particularly for this kind of surgery because it's such a long, complex surgery.
And we're quite lucky because, I suppose from a plastic surgery perspective, we do a lot of trauma as well. So we have our own operating theatre to address trauma. But in a lot of hospitals, such as James's, for example, they have to cancel elective surgery to facilitate the traumas. So that's why, for us, the South Infirmary would be ideal because there are no trauma patients that come through that way. So that's another issue as well, and Cork now is a major trauma centre, so everything gets siphoned into Cork and, with minimal expansion, but yeah.
Can I ask sorry, apologies, but Trina mentioned earlier, maybe using the private hospitals to take on the waiting list maybe of the surgeries?
So that's that's an access to care program. It's a HSC funding pot, I suppose. That's anyone waiting a long time for a procedure. So it's like the National Treatment Purchase Fund, but it's a particular sort of fund that the hospitals can, you know, now obviously the hospital itself, so your own consultant has to select who to refer out, we'll say, but yeah, that can be used, you know, if you're on a public waiting list, you know, they talk to your consultant, see if there's an option for that to happen. I mean, it's not the sustainable solution, but it's just for people that are on a list for, you know, 2 years waiting for your surgery and that. I mean, it's
Possibly get cancer in the waiting period, which is.
well,
ridiculous.
absolutely. I mean, it's not,
Yeah.
you know, I always think if you're going back for your surveillance again, since you decided you wanted to have the surgery and the, you know, I just think that's not, that shouldn't be happening, you know,
Yeah.
that you should be, you know, you've made that decision, you should be well on the journey. And I know there are clinical reasons sometimes, you know, there's reasons, health reasons maybe why someone mightn't be fit for surgery at a time, but if you're well, otherwise you've made the decision and you're have a, you know, a choice of surgery you want to have, you know, there's no reason it should be years, it should be, you know.
It's called preventative surgery for a
For a
reason.
reason, absolutely, you know, it's like.
Yeah, cheaper for the healthcare system too.
Yeah.
They're waiting for someone
Absolutely.
to get cancer, yeah. So we'll take one more question. Yeah, sorry, it's just conscious of time. If somebody had a hand up, and we'll come to you. Yeah, of course. Please do. Apologies again about the mics.
It's kind of a left field question, but it's really kind of for the genetics people. How do you think AI is going to affect this whole field?
A really great question. This week I went to the All Ireland Innovate and Connect conference in relation to digital technology and how it's going to be used in the precision medicine space with like twin modeling and using these AI pieces of technology to transfer the genetic data from the tumor to align it to the EHR record to match people's clinical trials. So there's a huge amount of potential, I would say, in the use of digital tools and AI in healthcare in general. I was really fascinated by that particular kind of example of how this tool could harness all this genetic information with really well-defined data fields to then match it to a patient to allow it to, you know, be targeted in its approach. A lot of information that the system currently captures in some way, but maybe not in an effective way to allow there to be kind of robust ways of processing that information. So what I would say, I think we need to have public-private partnerships with academia, industry, and with healthcare providers to plan for how AI may be developed, co-created with patients, how that could be implemented in a system, and how you like I was talking about health services research, how you actually translate that into a safe way of a system adopting it, but also for patients' information to be used in the right way as well. There are lots of tools out there, like there's growing numbers of tools. They need to be evaluated. They need to kind of be adopted, as I said, in a safe way for patients. But I would welcome that in the genetics field. We're under resourced. We're under resourced in lots, and it's not just Ireland. It's in lots of different health systems. That these tools will augment what we do. Yeah, they have to just be designed well.
I might just add from the surveillance space, you know, so when you're looking at your breast imaging and sort of the best practice, if you're looking for something in breast imaging and you don't have a symptom, so you don't know, you know, a particular area of concern and you're trying to check the whole breast, like the gold standard is to have 2 people, you know, checking those scans, and obviously the same as getting into a scanner and having a radiographer, it's having the person reading the scan and having 2 people check it. And that's probably one of the spaces you'll see AI come into first, that the second person, the second reader will be AI. So it's not that AI will do everything that the humans are doing, but it'll be the check beside you. So that would be good, because you'd say it's like doubling your number of breast radiologists overnight in a way, if that's to come, and they do think that'll be one of the kind of practical ones that will come soon.
Yeah.
Probably know from
Yeah,
your colleagues.
it's coming quick, I'd say, in the next kind of 5-10 years. They expect that it'll be.
So those kind of examples, I think, as well, which might be, you know, good for the service in general, but particularly for the surveillance side of things.
Ask me another question.
Surgery specific question. I'm after a long time. I'm scheduled to Justin is going to do my DF surgery in June.
And just in one of the pictures, I'm gonna go for nipple sparing surgery, I suppose, and it was the first time I've seen an image, which is really helpful, of actually what that looks like underneath post. And you mentioned that there's that flap of stomach tissue. At what point is that, do you have to have a revision surgery to have that removed, or is that something that is a kind of it just hasn't come up in any conversations, I suppose, we've had to this
Yeah.
point?
Yeah.
So it's just to see if that's something that has to be done, or is it something that will be a clinical decision at some point?
No, so any further surgeries beyond the initial reconstruction is purely elective. It's completely up to you whether you want to have it done. In some patients, it actually integrates really well. It's underneath the fold of your breast anyway. You might say, you know what, I actually don't see it. It's grand, just leave it. But if you do decide to have it electively removed, the choice is yours. When you do it, you usually time it with any other further revision surgeries that you may decide to have. But it'll be a minimum of 6 months anyway. Just allow all the swelling, edema to settle down, and for the breast reconstruction to sit where it wants to sit before doing any further revisions. So that is my access point in terms of in the situation where you're sparing the nipple. You know, Justin might have a different approach to it, but
It's
yeah,
similar, I think.
Yeah.
Yeah.
it mightn't be as big as that. It might just be a really small little thing that can be even removed under local anesthetic sometimes.
And can I actually add on to that? And just ask if, like, say, in my situation now, would you still have that visible underneath, considering I've already had the implants in?
Can't really tell because your situation might be completely different. So yeah,
No problem.
yeah. You would need a formal assessment for
Yeah.
that. Yeah. But I'm happy to chat to you about it.
Thank you, that'd be great.
And I know Jemima
Right.
mentioned about nipple tattoo, and you know, we do have Aisling Murphy as a stand outside, and that's a nipple tattoo artist. So I think we should take a break. Is that okay? Should we get this all sorted up here? Thank you.